So I'll be talking briefly on various traumas associated with urology. Um, I'll just highlight the important aspects in trauma. I would not be going details into the specific managements. However, I will highlight what is required, especially when you are a general surgery approaching urological trauma, when you are called for urological trauma. So it'll a brief introduction will be there. Then we'll talk about various organ specific trauma and approaches and its management. So what is trauma basically? Trauma is any injury that occurs to a living tissue, and there can be intentional trauma, which is surgery that we elective surgery that we do. However, there is unintentional trauma, which can be iatrogenic, but most often when you talk about trauma, it's those accidental injuries that happen um, in various modes, like motor vehicle accidents, fall injuries, and other things. Um, the incidence of trauma is variable, and the incidence varies according to the organ involved, and the organ involved varies depending upon its site, its mobility, and the site of injury. So the most common organ injured in urological perspective is kidney. Though it's in the retroperitoneum, its injury is higher, as I will talk, because it's organ which has a fixed point at places. However, overall the organ is mobile. So we have the pivot and a mobile head. So when it moves, then the chances of injury is very high. And the most common cause of renal trauma or any urological trauma is the motor vehicle accidents, which has gone down a little. And iatrogenic injuries are usually the most common injuries that we are facing these days because of minimally invasive surgeries that is on the rise. So what happens when the patient comes to you with trauma, and whether you are any a urologic surgeon or a general surgeon or a GI surgeon, the basics of trauma should not be forgotten, and stabilization, the ABC of trauma, is still holds true. So the thing is, you have to see all these things and prior to diagnosing what trauma has occurred. Mm. And in the meantime, uh, we have to investigate the patients from the ER. And while we are investigating, we'll want to know what are the effects of trauma, or what amount of blood has been lost. Then we want to know what kinds of injuries has occurred in the patients. And treatment basically can be divided into three. Uh, that is the it can be a supportive treatment, and supportive treatment means you may have to splint the patient, you may have to give analgesics, you may have to give antibiotics, IV fluids, and then once the patient is stabilized, then we go for either a surgical intervention or a conservative care. And mind it that this conservative care does not mean you just forget the patient after admitting the patient in the ward. And these patients needs to be carefully monitored, especially within the first 24 hours, because with resuscitation, some vascular injuries can open up because the blood loss may be low. There may be vasospasm. As the fluid is being given, this vessels can dilate and start to have rebleeds. So you do not miss those. And some injuries are, they present late, like even bowel injuries. You may not be able to evaluate patients because of pain and hematoma. You may think it's because of that, but it can be bowel disease. So careful re-examination and reassessment is very important. And then comes the surgical intervention. It depends upon the severity of trauma, organ involved, and all the things. So let's go into the organ specific trauma. Uh, Renal injury is the most common injured organ in urology, and it seems that 1 to 5% of kidneys are involved in trauma when trauma occurs. And good thing is majority of these traumas are of low grade, and only around 20% tend to be high grade. Um, and trauma can be either blunt or penetrating, and most of the time this can be just found out with a simple history, and history taking can delineate what kind of trauma it is. And blunt trauma is, I think, the most common type of trauma that we encounter. And motor vehicle accidents are the common source of this trauma. However, fall injuries are also there, especially in kids. Uh, Blunt trauma, the extent of injury from blunt trauma is basically determined by the extent of acceleration and deceleration. So, because of the inertia of movement, the body stops, but the organ does not stop. And as I told prior, um, the hilum and the UPG is relatively fixed as compared to the kidneys, which is mobile. So you have a fixed part which stops its movement as soon as the body stops, but the kidney is still moving. So this results in injury to the kidneys, impact injury to the kidneys. And the severity of trauma, that means the site of trauma when the multiple rib fracture that is occurs as a result of high grade trauma, the risk of renal injury also increases. And penetrating injuries are uncommon in our setup, but they do occur. And any injury um, to the flank anterior to the anterior axial line can involve the hilus structures, and that can have severe impact on patient's stability. Gunshot injuries are not common here in our country. But one of the things, caveats of gunshot injuries is the entry wound does not really tell us the extent of damage, internal damage that can occur, and the damage is much higher and larger as compared to what the entry and exit would suppose. And whenever you think about traumas in urology and any other system, you have to think of the surrounding viscera and the chances that other organs are also going to be injured at the same time. So, how do you suspect the kidney has been injured? One of the foremost thing that happens when the kidney is injured is the blood in urine. But you have to be very careful that not all traumas can lead to hematuria. It can be gross hematuria or microscopic hematuria, and you may not see blood. And in certain cases, even in severe high grade injuries, hematuria may be absent in about 1/3 of cases. It can be either as a result of uh, direct disruption of the ureteric UPJ, which leads to absence of urine flow distal to the site of trauma. Or it can have ischemic injury where rather than bleeding, it just had there is no blood to the kidneys. So degree of hematuria does not always correlate with degree of injury, but degree of hematuria increases the possibility that injury has occurred to the kidneys. And if, however, if only hematuria, if you investigate patients having having hematuria for renal injury, as high as 1 out of 4 renal injuries can be missed. Next thing is if you have a hematuria, gross or microscopic, and have hypotension, the chances of severe renal injury increases. So hematuria and hypotension, when you combine, the chances of renal injury is very high in this patient. You have to suspect renal injuries. And the injury scale. This is very important in the fact that grading is important because when the injury grade is low, like 1 to 3, the success rate of conservative management is very high. So staging a renal injury is the most important thing that determines what treatment the patient may require or what treatment the patient will undergo. So it's very important that you stage this patient, s- it can be graded from 1 to 5. So from simple hematoma to shattered kidneys, and grade. One of the differentiating points, important point, is whenever there is a urine leak or pelvic calcium injury, then this tends to be grade 4 injuries. That's the one thing that differentiates grade 4 injuries from 1 to 3, where there's just bleeding without involvement of the pelvic calcium system. And when the pelvic calcium system is involved, the chances of patient requiring intervention is high. And then when the main vessels are involved, then chances of having surgical intervention or radiological intervention increases in these patients. So whenever a patient comes with hematuria, and mm, then do you need to image these patients, or we can clinically evaluate this patient and say the patient doesn't have an injury? So whenever patient has a penetrating injury to the flank, especially in the lower chest, flank, back, then all these patients should be staged and suspected of having a renal injury. As I told before, rapid acceleration and deceleration injuries like motor vehicle accidents or fall from height should be suspected of having a renal injury if patient is hematuria. And patient with hematuria having a blunt have history of blunt trauma abdomen, or patient is hypotensive, or you have a microscopic hematuria associated with blunt trauma, then these patients should be imaged so we can stage these patients. In pediatrics, the difference in pediatrics is the risk of renal injury is very high in pediatrics because of the low amount of perirenal fat that's present. Uh, the ribs are not covering the kidneys, and moreover in pediatrics the chances of multiple organ injuries is higher than adults. So if you have renal injury, chances of other solid organ injuries also increases. And the caveat in pediatrics is because of they have a high sympathetic stone, these kids develop hypertension only when there's a significant more than 50% of the blood is lost. So hypertension is not a sensitive criteria as to to say the patient's child needs imaging or not, as compared to adults where hypertension occurs early. And these pediatric patients often have congenital anomalies like UPCU or horseshoe kidney and dilated system. So the chances of injuring this already abnormal kidneys is high. So how do we investigate patients? Um, Now most of the time the CT is available everywhere. So majority of the time when we are called, or you probably you are called, most of them would have undergone CT following stabilization of the patient. That's very important. So what's we as a urologist, when we are called, what we don't like is they have gotten CT, they have done a contrast study, but it's most of the time it's an immediate film. In other solid organ injuries, the immediate film may be sufficient. But for a urological perspective, a delayed film more than 10 minutes. Usually, the excretory films are taken around 3 to 5 minutes time. Then you get an excretory film. But in case of this trauma, a delayed film, 10, 15, even uh, 15, 20 minutes film is a must. If you don't have this film, then you may miss, especially pelvic calcium injuries. And what do we see? We see the staging of the trauma. Apparent what the parenchymal injury is not there. We see contrast extravasation. Contrast extravasation can occur early, like a vascular blush if it is the arterial injury, or in the nephrogenic phase if there's a parenchymal injury. But most importantly, you need to have a delayed film to evaluate if there is a pelvic calcial injury, because most of the time these pelvic calcial injuries requires surgical intervention. And we also need to see are there any associated injuries which is important if the patient requires surgical intervention or not, as compared to patients having only renal injury. And one of the things that we tend to forget is look at the other kidneys. So that's very important. The presence or absence of kidneys makes this patient a candidate where preservation of the kidney may be of utmost importance if this patient already has a damaged contralateral kidney or has an absent kidney. So see the other kidneys, not only to see for injuries, but to see whether the normal other kidney is normal or not. And so um, what uh, tells us that the injury is highly significant. That is when the hematoma is in the medial side of the kidney. That's in the area of the hilum. Then we think that the chances of having a major vascular injury or major leak is very high. Lack of renal enhancement tells us that it's a major vessel thrombosis. So it's a high grade injury. However, most of the time, surgical intervention is unhelpful. And whenever there is a large medial hematoma, some say 3 centimeters, some say 4 centimeter, a renal laceration in the medial aspect, or a acute early vascular blush, then the chances of having major injury and the chances of these patients requiring intervention is very high. And another thing that's missed often in this is amount of renal parenchyma that's devascularized or damaged. So when the more than 25% of the renal parenchyma is devascularized, then these patients are high risk of having delayed hemorrhages and high risk of having requiring any intervention in the meantime. However, CT is very poor at poor for detecting of venous injuries. So that's something that you should take up. However, most of the venous injuries they tend to heal without significant impact because of the compression itself and thrombosis, and because it's a low pressure system. Uh, Historically, one-shot IVP was talked of in patients who were unstable, who were unable to undergo CT scan, and requires early surgical intervention. Uh, this scenario is very rare, but it's very important theoretically, and the most important thing to see in a one-shot IVP is to assess the contralateral kidney renal function, because if the contralateral function is not there, is absent, then it's very important that you don't do a nephrectomy in these patients, and it's very important that you preserve these kidneys. However, the sensitivity is quite low, and sensitivity is quite low, and usually most of the time palpate by you see the whether the other kidney is present or not by just a palpation, see the size of the kidneys. So that will guide you whether the contralateral function is okay or not. And yes, contrast extravasation it's written, but it's very difficult to assess this intraoperatively because of the logistics that's involved. So most of this has been only of long gone past, and no one usually does it. Um, so focus ultrasound. What's the role of ultrasound in renal trauma? has a very poor specificity in cases of trauma because of the pain, because of the gas, and the most of the operators are inexperienced in trauma and are junior residents or so. Ultrasound can miss significant renal injuries. So one of the things that ultrasound does help, as with a single short contrast, is it can at least tell you there are two kidneys. So that's a plus point. And so fast is can be used, but cannot be dependent upon for evaluation of renal trauma. However, what we can do is a patient having a bilateral normal kidneys without any perirenal damage, and patient having hematuria, minor microscopic hematuria, then these patients may not require any contrast in CT scan. In this case, if the patient is stable, so that can help you guide whether the patient will require a renal evaluation or a delayed film or not. So that can help in that way. So how do you manage? ABC is there. Pre-op stabilization of the patient is very important. Uh, One of the most important thing in renal trauma management is adequate investigation, adequate imaging. So the management has to be based on whether the patient is stable or not, and whether you can classify this injury in various grades. And conservative management is the norm. It's the standard of care in low-grade injuries and even in grade 4, grade 5 injuries. The success rate of non-operative management is very high. With interventional radiology and the minimal invasive surgeries, open surgeries for a high, even for a high grade renal injury is very low. And the success rate of non-operative management as high as 90%. And these have a very high renal preservation rate in contrast to open surgery. Most of the time, when open surgeries are done, then they undergo nephrectomy. And as I told before, it's not just admit and leave. It's active observation. You have to see the vitals. You have to keep the hematocrit. You have to monitor the output, see hematuria is clearing, not. And there is no in non-operative management now with the interventional radiologist, angioembolization does play a role in renal trauma, and I think the renal preservation rate has significantly gone up with the use of um, intervention radiology in many aspects. And one of the things that help us is like when we are doing percutaneous renal surgery, PCNL, is actually a grade 4 injuries. So, and there has been incidences where patient has undergone nephrectomy post PCNL and previously, but angioembolization has really helped prevent all these unwanted outcomes. So, however, when if you are managing the patient conservatively, if the patient has high grade injuries or penetrating injuries, the chances of conservative care failing is very high. So you have to be vigilant in patient's condition deteriorating, uh, in detecting the deterioration in patient condition like fall in hemoglobin, vitals, deteriorating vital signs, decreasing output. So these patients required intervention. Bed rest, yeah, clinically, classically, we're taught that absolute bed rest till hematuria clears up. There's no data, actually, any trials or any articles to support. I have a good support on bed rest. It's an empirical practice, and most of the time we do advise these patients rest for at least 2 weeks post trauma. However, there is no data to support that, so it's an empirical practice which has been done, and still we are doing it. And thing is, even if the patient is doing well in high grade injuries, it's advisable to repeat a CT after 48 to 72 hours just to see what's going on, especially if patient is having a drop in hemoglobin or increasing hematuria not clearing up, febrile, patient is developing ileus, abdominal distension. And so if the patient is not improving, then a repeat CT scan is a must to see what's going on. And you have to be vigilant that these what we ask patient to wait, have a bed rest for up to 2 weeks, because delayed hemorrhage has been noted can occur up to even 4 to 6 weeks, but most of them occur within 2 weeks, most of them within 7 to 10 days. So this is the time. That's why empirical which is do a bed rest, follow up after 2 weeks and see how the urine is clearing up, whether patient is stable or not. And if patient is having a repeat bleed or continue bleeding, then most of the time these patients require embolization. So what are the indications for operative management in an era where majority of the patients are doing well with the conservative care? So the absolute indication for intervention in a renal trauma is when if the patient has a renal trauma, gross hematuria, and patient is unstable, that you persistently due to undergo transfusions going on, IV fluid is still going on. Despite that, the systolic blood pressure is not picking up beyond 90, or mean arterial pressure not going beyond 60, then probably these are patients which require intervention. It may be surgical or in minimally intervention radiological surgery, and expanding pulsatile renal hematoma. So this is though we cannot detect it prior with investigation. This is been listed here because if the patient is undergoing surgical intervention for other trauma like bowel injuries, or going surgery for a liver injury, then if the patient is you see a renal huge hematoma which is increasing in size, increasing in size as compared to when you open the abdomen. The patient is vital signs are deteriorating despite your control of solid organ injuries like liver, spleen. Patient is deteriorating. Then you see this hematoma, palpate it, and most of the time in the medial effect, if there's a increase in size or the pulsatile nature of the hematoma, then you need to explore these patients intraoperatively and control the bleeding. And suspected renal pedicle avulsions, most of the time this can is seen by medial extravasation of contrast, as I told you before, or medial kya le, medialization contusions, and there is injury in the laceration in the hilum, or there's a perineal diffuse contrast leak, then most of the time these patients have had renal avulsion and this requires surgical intervention. UPC avulsion is something that has to undergo surgical intervention. However, if the patient is unstable, it can be managed with minimally invasive treatment like percutaneous nephrostomies. And so we'll talk about that later. And in CT, UPC avulsion can be seen with a contrast leak, or if there is no leak, we have to see whether the distal ureter is opacified or not in contrast in delayed film. If it's not opacified, then chances of having UPC avulsion is very high. And relative indications are urinary extravasation with significant renal parenchyma devascularization. Well, there's a relative um, significant, meaning if the renal parenchyma damage is more than 25%, the chances of having a persistent leak urinoma is high, so may require surgery. Associated colonic or pancreatic injuries, this is a related now. It's not mandatory that patient has a injury and then you need to also take care of the renal trauma, because what was thought was because this is infective foci, the the hematoma will get infected. So you treat this patient, drain the system, prevent urine leak, then chances of complication will decrease. But this has not been shown in studies where even a conservative care with patients undergoing laparotomy for colonic pancreatic injury, the renal kidney has healed excellently. Urinary extravasations, most do require treatment, and arterial thrombosis. Arterial thrombosis is though relative is not indication where we would like to operate, because the outcomes of intervention is very poor. The possibility of saving the kidneys is very less because the patient present lead and despite revascularization, they don't do well. So most of the time we don't intervene, we just leave it to undergo atrophy, and then follow these patients up. So in operative management, minimal invasive management, stenting, especially if you're PCS injuries, we stent the patient, put the patient on catheters, put PCN if there is a urinoma or urine leak, and then absorb. Uh, the PCS injuries heal in more than 80 to 90% of the time without any further treatment. So you need to give these patients on antibiotic prophylaxis, and they do well with this treatment only. And PCN can also sometimes help with anti-gate stenting, especially in patients who are unstable, like they can't undergo they don't need to go undergo general anesthesia. So PCN can help even with stenting without undergoing general anesthesia as compared to ureteric stenting. And open exploration is very uncommon these days and can range from repair, rhinography, partial to total nephrectomies. Open exploration is a very difficult and one of the most difficult renal surgeries, so it should not be taken lightly. I have known someone who explored grade three injuries. General surgeon who explored surgeon explored grade 3 renal injuries, and which did not require surgery, and that patient 25-year-old patient underwent nephrectomy for that cause, and it feels bad. So open exploration, if the patient requires most of the time these patient will undergo nephrectomy. And so this is highly technically demanding surgery. So if the patient is stable enough to be transferred, I think it should be done in centers with experience in renal trauma. And the thing that you must take care if you ever need exploration of this patient is: number one, vascular control is the prime important. Don't open the gerota, go to the vessels first. It has been shown when the renal vessels are taken in control, the chances of preserving the kidneys is very high. 70 to 80% of the kidneys are preserved when the vascular control is taken, as compared to direct exploring the kidneys without control. The chances of preserving this kidney drops to 10 to 20%. And what you need to do is open up the peritoneum anterior to the aorta. Find the aorta, open the peritoneum anteriorly, go to the renal vasculature, and then get a control. So where to open is: you find the inferior mesenteric artery. Above that, go proximally, then you will find renal vein. As it crosses the aorta, then you can see the renal artery just lying posterior to it. Easier said than done. Most of the time, hematomas are large, and it's a very difficult surgery. So that can be done. Rhinography is simple suturing, can be done. Nephrectomy, most of the time, partial nephrectomies become very difficult, so they undergo total nephrectomies in this case. So to summarize how treat this patient is very important, because this is the most common trauma that we encounter, and most common cause that you'll be called upon. When the trauma is blunt, if there's only microscopic hematuria and the patient is stable, you can decide whether to image with CT or not. If there's gross, if patient is stable, just do an ultrasound scan. If you don't see anything in the kidneys, then you can just leave this patient and clinically follow up this patient for to see whether they do well. If they don't do, you always can do a CT scan. If there's trauma, blunt trauma, or penetrating trauma. In terms of penetrating trauma, even despite the patient having microscopic hematuria, without shock, if there is blunt trauma and patient has gross or patient has shock, then imaging is a must. And if the patient is unstable, you have to explore. Sometimes, if the patient is stable, then primary intervention would be non-operative. However, you have to explain to the patient when the grade of injury is high, the chances of this patient undergoing surgical intervention or embolization is high. You have to counsel the patient, observe, and see. Majority of them do well. It's rare that the patients will require a surgical intervention, even if the renal injuries are grade 4, grade 5. So what are the complications? Uh, urinoma and urine leaks are very notorious if there is a PCS breach, and can be managed with PCN or stenting. Delayed hemorrhage, as I talked to before, can occur up to 2 weeks, can occur up to even months, up to a month, but most of them would occur within 2 weeks. Abscesses, if there's contamination from the urine, and most of them require drainage. And one of the two theoretical things that can occur is hypertension. This patient needs to be followed up with serial monitoring of blood pressures. And gallbladder and P's kidneys are basically, gallbladder kidneys when there is ischemia as a result of injury. So renal parenchyma is ischemic when there's a vascular injury. Then this activates the renal angiotensin system, and then hypertension is there. Paced kidney is basically a compression of the kidneys by a subcapsular hematoma, and it causes ischemia to these kidneys and can cause hypertension. AV fistulas can cause ischemia and hypertension. And these patients require follow-up for functional loss also. And if the patient is you have a patient with renal trauma, and they want, if you feel the litigation problem is there, then assessment of this function around 6 weeks time to see by doing a TTP may be important, because the patient may see come to you because you said the kidney was fine, and the now the kidney is non-functioning. So you can follow up this patient with a DTP at 6 weeks and then at 3 months to see whether the function is deteriorating or not. And you have to tell them the kidneys can deteriorate with time. So next is after kidneys, I think that's the most important injury as a general surgeon, as a MS resident you're going to face. So, and the good thing is most of them require conservative care. Ureteral injuries. Now the ureteral injuries are on the rise, not because of trauma, but because of surgeons itself, because of endoscopic surgeries, the laparoscopic surgeries. The uterine injury has really gone up, and the blunt and penetrating injuries um, are low, and the chances of having a ureteric injuries is low despite having blunt trauma. And when there is a ureteric injury, then most of the time these injuries, this trauma is very high grade trauma, and concomitant or other organ injuries are very high. And most of the time the eye tracing injuries, as a general surgeon, you may not be called upon. One of the thing that a general surgeon might take into account is ureteric injury during mobilization of the sigmoid colon or the cecum. So how do you prevent that? Most like recognize where the ureter is, then only do a mobilization. And with laparoscopic approaches, doing a stenting to prevent ureteric injuries. In open surgery, maybe it's helpful. You can palpate the ureter with the stent, then avoid injury. But in laparoscopic surgery, the stenting the ureters has not been shown to reduce ureteric injury as such. So stenting may not help in laparoscopic surgeries. You have to identify the ureter landmark and then only do surgery. So that can be, and other area where ureteric injuries can occur as a general surgeon is doing an APR or a TME. The chances of injuring the distal part of the ureter is very high. So mechanism, how does the ureter gets involved? You may not need a direct trauma. So if the vascular supply is damaged, it can be damaged as a result of thermal injury. So when you are using a cautery, you are using a harmonic. then the heat itself can damage the damage the descending and ascending vessels vessels and cause delayed vascular ischemia and cause strictures, especially in gynecological surgery. So, in these these cases, you may not require a direct trauma. And with open surgeries, the detection rate of ureteric injury is quite high. Yeah, patient you can detect the ureteric injury and manage at the time. However, during laparoscopy, the detection of intraoperative detection of ureteric injury is very poor. So unless you have a high index of suspicion, the chances of missing ureteric injuries intraoperatively is also high. As with renal trauma, hematuria can be there, but in contrast to renal trauma, hematuria, the incidence of hematuria is low, even despite having a ureteric injury, because if you transect the ureter, then the distally the urine does not go and you may not have visible hematuria. So high degree of suspicion is required if there's a trauma in and around the ureteric area. Mm, so if you suspect a ureteric injury, always it's always best to explore the ureter intraoperatively if you are already intervening for some other purposes. Uh, and another thing that you can do to rule out ureteric injury is to either do a retrograde ureteric catheterization and do a saline injection. So that can help. Indocarmin is not available, but if you give an IV, it tends to make the urine blue, and you can see the urine leak. That can be done, but most of the time, it's retrograde saline injection has a very high sensitivity and specificity for detect ureteric injuries. In CT scan can help you identify ureteric injuries. And in ureter, you need to see the ureteric opacification, which is important. If you don't see a ureter being opacified, then the possibility of having a ureteric injury increases. Then you can see leaks, delayed nephrogram phase, especially results in absence of leak. And if there's hydronephrosis, the chances of having a injury is very high. And the most sensitive, as I told before, is a retrograde study, and it is only done if the patient is stable, or most of the time we do it because the patient is suspected of having a urinary leak and patient is stable. We do a retrograde pyogram. After that, we want to stent this patient. Only at that time we do it. It's not an investigative procedure as such, but most of the time we are planning for a stenting. Then before that, we do a retrograde pyelogram to see where the injury is. If your patient, you put a PCN in a patient, then you can do an anti-gate pyogram that can help. IBP has a very low, low sensitivity, so not done. It's all done with CT these days. And the grading of injuries is depending upon the degree of transaction and whether it's completely transacted or not. So most of the time, the partial transaction and grade 4, grade 5 are total transactions. So what do you do if the ureter is involved? If you are called intraoperatively, and then it's best to repair at the same time. However, if you are not experienced enough to do a repair, then don't fiddle around, because the chances of making a simple transaction into a long segment ischemia and a complex surgery later on is very high. But if you see the ureteric repair follows the same principle as a bowel repair. It has to be, in contrast to bowel repairs, however, the ureteric repairs has to be of spatulated. It should be stented, always stent. You should always drain the area of repair and do a watertight closure with a observable 4-0 Vicryl is good enough. And you need to mobilize without devascularizing the ureter, preserving the peri-adventitial tissues. However, if you are not very confident, just do a damage control surgery. So we'll talk about damage control in a little later. So what to do? What to do in cases for injured ureter? Then it depends upon site of injury and the length of segment loss. So that will determine what to do. And immediate repair is uh, is advisable if within a week. If not, then just divert the urine and wait for 6 weeks for all the hematoma and inflammation to heal down prior to surgery. Contusions, that is grade one injuries, uh, you just need to stent this patient. If you think the ureter is vitality is compromised, then you need to do excision anastomosis and then do stent. So ligation, same thing, release and stent. If non-viable, then you have to resect and do a ureterostomy. And damage control can be done by just ligating the proximal ureter, just with a non-observable suture like proline or is best. Ligating distal ureter if there is with or you can leave the distal ureters and then do a percutaneous nephrostomy with the help of a radiologist post-operatively. So just ligate it and leave it. So you can identify the ureter and you won't damage, do a vascular damage of these ureters. So as I talked before, grade one, grade two injuries where there is only partial injuries can be just stented. If you can't stent it, then open repair may be required. Grade four, grade five injuries most often require an open repair. So what do? And you can do a ureterostomy in upper and mid ureter. However, lower ureter it's advisable to do a reimplantation. So sausage is required if you have a long segment distal ureteric loss, more than 2 centimeters, and direct ureterostomy can be done in defect up to 2 to 3 centimeters. You can, but sometimes to anastomosis this anastomosis sometimes renal mobilization may be required to bring the kidney down and decrease the tension. And sausage can cover up to 5 to 8 centimeter distal ureteric defect. Similarly, you have the Boari flap can be done. However, most of this treatment is an elective procedure rather than emergency. If there's severe injury, if you can't reimplant, most of the time, just do a damage control, assess the injury later, and then plan, because these are big surgeries. And in a trauma who are unstable, patient are unstable, then you may not have the liberty of doing this extensive procedure. Bowel interposition, if there's a long segment loss, auto transplant has been done, and this is done if there's a long segment uterine loss and the bowel is unhealthy. Nephrectomy may sometimes be required, especially if you have a vascular avulsion or you have a very shattered kidney where salvage is impossible. These patients need to be followed up for delayed complications, especially strictures with imaging at 3 to 12 months, 3 and 12 months to prevent renal function loss following complication of strictures. Next common thing that as a general surgeon you probably call upon is the bladder injuries. Uh, they can be blunt or penetrating trauma of the bladder, and most of the time is the bladder is involved. 95% of the time, the pelvis is also injured. However, if the pelvis is injured, the bladder may not be injured at the same time. So, uh, when the bladder is full, the chances of having an injury is high. And bladder injuries, most of the time, you'll be called is when the gynecological surgeons are doing um, the mobilization of added uterus, or even in CS, most of the time they can call you, and then you can have a iatrogenic injury. Types injury, it can be extraperitoneal. Most of them are blunt injuries in an empty bladder where there's a fracture and the kidney ruptures. Intraperitoneal injuries occur in full bladder with trauma is lesser amount of trauma and in penetrating traumas, then intraperitoneal injuries are occur. This is very important to differentiate these two because management is extremely different in these type of injuries. Clinically, it's very non-specific, can't determine whether the bladder is injured or not, but because the fracture and the hematoma will simulate the pain, tenderness, and can mask it. However, if the patient has trauma in the lower abdomen, and patient has no urine, patient is have a tender abdomen, there's superficial bruising, and you feel that bowel sounds are absent, and when you catheterize this patient, you don't have urine, you only have clots, then you need to suspect there's a bladder injury. And suspect rupture if when you do an ultrasound, you see free intraperitoneal fluid. You can differentiate it from clots because of the density of the fluid. And if the patient, despite adequate resuscitation, fails to produce urine, the bladder is not distended, and there's huge amount of clots in the bladder, and then you need to suspect bladder injury. And as I talked before, abdominal distension, ileus can occur. Creatinine can rise because of the urinary creatinine being observed. So you may, if you miss this patient, then sometimes the raised creatinine can also help you suspect that there's a urine leak. And enlarged scrotum ischemia can occur as in bladder injury as well as pelvic trauma, more so because of pelvic trauma rather than bladder injury as such. Cystography is the gold standard in doing identifying a bladder injury. So, how to do cystography is very important. What you need to do as a surgeon is just put a catheter, polycatheter needs to be inserted. Then you need to get a dilute dye, instill around 300 to 350 ml of contrast. I'll talk to you how to do it a little bit later. And um, you don't need to stage this patient for upper tract injury because it's uncommon to have lower and upper tract injury at the same time. And so, as I talked, around instill around 350 ml of contrast, and there are three films that is required. Number one, you need to do an X-ray pelvis pre-contrast installation to see whether there is any radio opaque shadows prior to installation contrast. Then you do a full bladder anterior-posterior films after installation of around 350 ml, 300 to 350 ml of contrast. And then you do a post-drainage film to see whether there is residual urine or to see whether dye leak, because you can't see the dye posterior to bladder. And adding a lateral film can is sometimes helpful to detect minor leaks. And if there's a dense flame-shaped uh, shadow, like on the one on the left side, then this signifies an extraperitoneal bladder rupture. But when the dye delineates any bladder or delineates the lateral peritoneal fold that you see here, just the lateral peritoneal fold, then this signifies the intraperitoneal rupture. CT cystography is another modality, very highly sensitive and very highly sensitive, and is a investigational choice. These days, the most important caveat in doing a retrograde contrast cystography is you need to feel the bladder manually. So it will be active feeling. You can't wait by clamping the bladder from an intravenous IBP film and wait for the contrast to settle down in the bladder. You need to fill the bladder with 350 ml of contrast, and the dilution is very necessary. You need to dilute in the ratio of 1:6 of because the contrast has a high density contrast will have artifactual effect in a CT scan. And if you see, there's a minor leak that can be seen in this shadow. So management, what we're doing if the patient comes in ER, just one thing is you need to catheterize this patient, and you'll find that hematuria is there, blood. But what you need to take care is see the meatus. If there's a blood in the meatus, then you need to suspect associated urethral injury, which can occur in up to 1/3 of cases. And if there's a urethral injury suspected, then management differs. We'll talk about urethral injury a little later. So, for extraperitoneal injuries, simple drainage can work until the cystography is negative. Usually, cystography can be done around 10 to 14 days later. And if there is still a leak in a 14-day cystography film, then it's advisable that you get a cystoscopy done, because if you have bony spicules in bladder, then they tend not to heal and they require open surgical repair. Antibiotics around 7 days is enough. And the thing is, if the patient is undergoing surgery for some other causes, then maybe surgical repair is better. So, for open repair, when is it indicated? If despite, even if the rupture is extraperitoneal, if you have inadequate bladder drainage, there's recurrent clot obstruction, if you suspect bladder neck injuries, if there's a rectal or vaginal injury, in open fracture where fixation is required because the urine leak can cause infection, so repair is prudent. If the patient is undergoing laparotomy for some other causes and there's a bladder injury, it's always best to repair. If the bony fragment impinging on the bladder post and in a CT scan, then you probably need to explore this patient and do a repair. And in cases of intraperitoneal injuries or penetrating injuries, immediate repair is required, and you can repair in a single layer or double layer. There is no data to support the superiority of one over the other, but most of the time we do a two-layer repair. One is you can do a seromuscular layer, then a full thickness muscle layer. Um, Intraperitoneal injuries do not heal because they are large and the omentum goes and plugs the opening, and the complications of intraperitoneal leak is very high. The patients are having sepsis, infection, abscess, is very high. So these patients need a repair. Once you do a repair, a cystogram uh, is not mandatory. You do it, we what we do is we usually remove the catheter after around 10 days time without a cystography. And if you need to repair the rectum or the vagina, then overlapping suture lines should be avoided, and tissue interposition is very important to prevent fistulas. Next thing is the urethral injury. Urethral injury, most common injury in trauma is the posterior urethral injuries. Previously, it was called a pelvic fracture urethral distraction defect. Now the terminology has changed into pelvic fracture urethral injuries. Um, and 10% of males with the pelvic fracture can have a urethral injury, well, female is quite uncommon. The site of injury in this case is the bottom membranous junction, because the membranous junction of the portion of the urethra is fixed with the puboprostatic ligament. The prostate is fixed, and with the pelvic diaphragm, it's fixed, and the bulbar urethra is mobile, and so this causes a distraction defect. So the junction of bulbar membranous area is the one that's injured, and and the chances of injury of urethra is high if there is severe distraction, like there's a pubic distraction of more than 1 centimeter, pelvic beam fracture distraction of more than 1 centimeter. The chances of injury is very high. And in children, the difference is that because the urethral length is very low, if there is a urethral injury at all, which is uncommon in children somehow, they tend to be severe and they can have associated bladder neck injuries in children. So this should be thought of. And the classical triad of urethral injury, blood in meatus, inability to void, and papal bladder, the high riding prostate, and butterfly peritoneum. This is a classical teaching in urethral injuries. And the butterfly peritoneum hematoma is results as a result of different attachments of the Cory's fascia, preventing leak into the thigh. And one of the most one of the things that most of the time will be called is by the ER physician is they pass the catheter. Either they could not pass a catheter or there's a bloody drains per catheter. So most of the time, what happens if they push the urethra into the urethra and there's a complete transaction of the urethra. Most of the time, the catheter is passed into the uh, into the hematoma and there's no urine at all. So that can occur. If you suspect urethral injury, what to do? Classical teaching is don't do it. Don't do a trial of catheterization. But but what we do is we usually put a small bore catheter. Try it once with a good lubrication. But if you can get a retrograde grade urethrogram, then that is the standard of care nowadays. So instead of trying with a small bore, well lubricated catheter, doing a retrograde ureterogram to rule out uh, urethral injury is the standard of care before catheterizing. And you can find partial tears, then you can just push the in the catheter that can go. And if in case of complete tears, then a catheter should not be inserted. And the definitive repair of urethra is to be done with the by the reconstructive urologist. Uh, Primary realignment is just a theoretical aspect of urethral injury. You can do a primary realignment, not in favor for the favor among most urologists because it requires them to go to the ER emergency and do a emergency surgery. Can be tried if the patient is undergoing general anesthesia or surgery for other causes and the patient is able to have put go into a lithotomy position. Then primary realignment can be tried. The advantages of primary alignment is thought to be that they tend to shorten the defect, shorten the structure, and make the surgery less complicated because you can just put the alignment of the proximal and distal the urethra. But the success rate of primary alignment has been low, and the chances of requiring secondary surgery is very high, 70 to 80%. And in delayed surgery, endoscopic OIU can be done, and anastomotic uretroplasty is the standard of care, and usually it's delayed after 3 months. In anterior urethral injuries, most of the time straddle injury or penetrating injury can cause it. And same thing happens with the blood retention, perineal hematoma, um, and sometimes with the blunt trauma to the urethra. We have had patients who come years after trauma with poor flow. And when you take the history, they say, yes, I had this injury. And when we see that, most of the time there's a ring-like structure in the urethra, and they require a delayed repair. And retrograde ureterogram will cleanse the diagnosis of urethral injury. So what, as a surgeon, we need to do? Number one, partial tears. You can put a catheter, do a retrograde ureterogram, and if you put a catheter and you suspect an injury, always confirm the past catheter placement with a contrast study. Sometimes what happens is that it may go into other places and you can not have urine in the catheter. So always confirm placement. And best thing if you suspect urethral injury is put a suprapubic cystotomy. And one of the things in suprapubic cystotomy is that this is not an easy procedure because if there's a pelvic fracture, there's a lot of hematoma. The bladder can be compressed, number one, with the hematoma. And because the patient is in shock, the distance of bladders may take time. Okay, so you may need to get the help of intervention radiology colleague to do a ultrasound guided cystostomy. And it was thought that it may increase the rate of infection in hematoma, but this has not been shown. And primary or delayed repair, if there's a minor just laceration or small laceration, small partial tear, then you may just go and suture it and put a catheter. Um, However, if there is massive repair, massive injury, then it's best to just put a diversion cystostomy and let the reconstructive urologist to take care of the healing. Because if you go and attempt this, then the chances of increasing ischemia, increasing the complexity of surgery may increase. Next is the testicular injury. This uh, we occasionally come across this testicular injury as a result of blunt trauma, and they can present with hematoma, hematoceles, can present with rupture, or even testicular dislocation and torsion can occur when trauma occurs. Dislocation and trauma torsion is basically as a result of severe contraction of the cremasteric muscles and usually occur in children. And can trauma can be blunt, penetrating, or developing injury to the scrotum and testis. How do you diagnose? Clinical in evaluation, you can see the swollen testis with hematoma and contusions. Ultrasound, you can do to detect hematoma, but one of the caveats in ultrasound is it has a very low sensitivity to diagnose testicular rupture. So you can miss testicular rupture in half of the time. Okay, so you must not detect just depend on ultrasound. If you suspect, then it's best to explore. Why? Because um, early exploration and repair has shown that the chances of testicular preservation is as high as 90% if you do repair it early. That is within even within 3 days. But when there's a delayed repair, the chances of patient undergoing orchidectomy is very high. So if you suspect rupture, there's a significant intratesticular hematoma with severe pain and is expanding. Even if there is no rupture, then you uh, require exploration. Large hematoma, hematoceles in testis, and by large, it's been written that if the hematocele or hematoma is more than 3 times the size of the contralateral normal testis, then these hematocells should be explored because the chances of having a testicular rupture is very high. And even if there is no rupture, if you remove the clots, if you drain the system, then the morbidity, admission, prolongation, admission to in the hospital is highly reduced. So if it is a large hematoma, we just need to explore it, even if you don't see any rupture. And ultrasound sonology, they usually see a defect in the tunica albuginea, or you can have a heterogeneous testis. And so then you can MRI is not used in emergency setup, but is very highly sensitive to detect injury. Penile injuries are uncommon. Uh, Fractures, we do occasionally see fractures, they come in crops. And it's basically fracture is a rupture of tunica albuginea as a result of increased intracavernous pressure. And it's said to be a result of coital trauma, vigorous bending practices, and the trauma occurs in the base, in the lateral, ventrolateral aspect, because it's the thinnest part of the corpor, albuginea, and majority of this is unilateral, and usual injuries are uncommon in penile fractures. However, if there's bilateral fracture, the chances of usual injury also increases. So how do you diagnose penile injury? The classical eggplant deformity is there. If you see on the picture, there's a classical eggplant deformity. Sometimes you can palpate and see the defect. And if the box fascia disruption is there, then you can have extensive hematoma extending into the scrotum walls. If in doubt, ultrasonography will identify the defect in the tunica albuginea, and MRI is highly sensitive. What do? Penile injuries, fracture penis should be repaired using sutures. 2G can be observable 2030 Vicryl. Even delayed repairs have good success rate, and there has been reported cases where they have done a penile fracture repair even after a month time of injury and with a good outcome. Once you repair this, tell them to have no sexual contact for at least 4 to 6 weeks. After that, they're good to go. Uh, Amputation, just need a point in penile injury. Amputation are very rare, but you do see it once in a while, and the most of the time require microsurgical repair in a highly specialized center. So most of the time, if you come across penile injury, it's plan this patient to be transferred, and to transfer it as with any trans injuries, cover this, wash it, and cover with the what saline soak cause, and then put it in an ice pack. And the repair with a success rate as high as 80% has been done in as delays as up to 16 hours, 16, 18 hours has been reported. But the best time to repair is within 6 hours as with any ischemic injuries. So just put this in a pack and transfer these patients. So I have not talked about subcutaneous tissue laceration, as I think most of them you managing lacerations, and laceration in urological practice has the same principle of management, debridement, and if primary repair if possible, or do a grafting in later day if there is a defect. So thank you. This is a brief overview on renal trauma. Hope you uh, hope I could make highlight some important salient points. And if there are any questions, queries, I'll be happy to answer them.
Hello, Bipin.
Yes, yeah. Hello, hi, hi.
Yeah, how are you? I think it was a very elaborate type of urological injuries you have described. It was very nice to hear from you. I think all the residents have enjoyed it. And then to the on regards to exam point of view, it was very interesting and it was very elaborate. I think we should ask the residents, anybody who wants to ask questions regarding their queries. I think the forum is open.
Thank you very much.
If you have any question, please ask Dr. Bipin, who has a vast knowledge about urology. It will be very helpful in your exam point of view also. If there are no questions,
It
I
seems
think we should.
I've been able to make everyone understand everything about trauma.
I think so. You have made it very clear regarding all the staging and all the urological injuries that happen. I think kidney was that the one you have elaborated very nicely. I really enjoyed it. Myself, I have enjoyed very nicely. Very
Yeah, renal injuries are the most common injuries that I
uh,
think we come across, and
yes.
so that's why I thought that's important. And even in the examination point of view, most of the time for non-urological as resident, general resident, surgical resident, I think renal trauma is the most common question that's
Yes.
asked in exams.
Yeah,
With
it is the
urologists,
renal trauma and the bladder trauma. It is usually
yeah,
asked to the resident.
yeah,
Bladder trauma and renal trauma
renal
is
trauma,
very important, staging wise and the diagnosis clinically also is
yeah.
very important. So I think all our junior colleagues should be prepared for the exams. If any, there might be some theoretical questions as well as practical classes during the Viva course. So I think if there are no questions, then we should say bye bye to everyone. And thank you very much, Dr. Pipin.